Yeah, you're correct. Absolutely correct. These are the ideal things that you're talking of. First of all, the aspiration cannula was being used because for polishing, it was not a polishing. There was a strand of cortex attached. It's a thick posterior subcapsular cataract or a PPC that is this strand which is attached to the posterior capsule. So it had to be aspirated rather than polished. And second thing, the whole margin of the total of the red could be seen, and anything that was going in or out could be well seen. Of course, it is always best to go with Ramsurama, but maybe.
I think Sudipta did very well because the people came down after Alolika. So again, in this situation, sometimes again it will you have to wash it out as well.
Yes.
Only thing I am trying to ask Sudipta because there was some irregular margin. You managed very well, but always there is chance of that increasing. So would you like to just trim it off with posterior capsular axis?
Yeah, that is ideal. Again, what you're saying is very ideal because then that if these margins they later on get fibrous, again it will get these one. So you are talking absolutely fine.
During the lens subject, it can
Open up, correct, correct. So that is why I said that I did not do an irrigation which is really 100% what I'm doing. I prefer to go with viscoelastic. So there was a layer of viscoelastic which was acting as a tamponade. So well, it is always when you can manage. Sometimes you can't.
You manage it very well. We have with us Dr. Shonti Banerjee as well, very experienced surgeon. Shonti, I would like to ask you if you are thinking of PTC and there is a strand. I am a cover surgeon. I would probably leave it alone because if you try to polish or vacuum the PC, there is always a chance of opening up. So, would you like to leave that small strand there, or you like to speak that?
No, I will not do anything heroic. I would definitely give that small strand as said. Because we have a lot of other options. Maybe we can tackle accordingly. If there is some lens tilt or in postoperatively we see there is displacement of the lens, then only we can think of. But the small strands, no need.
Correct. You're very correct. That is, this is the ideal situation which everyone from this platform. That is what we should actually say that it is better to live out such tracks. Sometimes something in your head goes wrong. So probably I was lucky in this case.
But you managed very well. Thank you. Thank you.
Thank you.
Thank you. So, give a big hand for Dr. Mitru, please.
So we move on to the next surgery. Due to shortage of time, we move on to the next surgery, Dr. Shonti Banerjee, sir. So he will be performing a case with clarion panoptic IOL of 24 diopter, the left eye of patient. This is the pre-op workup. Left eye is having 612 vision, aided vision of 612 with -1 diopter center, -1 diopter center. So the surgery plan is with panoptic IOL. We can see that the biopsy has been done, the surgery has been planned perfectly. This is an ideal way to plan for premium IOL where you have all the parameters, you've seen all the parameters, where to place the lens, how to go about.
Yeah, and any deferred eye surgery is always difficult for the first surgeon. So, Sudipta was doing in one table, she was the first surgeon there, and Hassan Tonji, he volunteered to become the first surgeon in another table. Sonji is a very experienced surgeon, so he will now demonstrate his surgical skill, and we hope to learn from his demonstration of the surgical techniques which he follows.
Thank you. Thank you, Shubhodana. Thank you, Alolika and Dr. Mondal for arranging this wonderful surgical session. Coming to the surgical This is a very normal, usual
the patient is having a degree of visual acuity, best corrected visual acuity of 6 by 18. The patient is opted for a trifocal Alolika.
Thank you, Shivashish, for the kind introduction. So I'll be doing a panoptic story and 14 variant is done. It's a left eye and I am sitting temporarily. My foot panel of the figure is with my left leg and the right I'm operating the microscope and I'm sitting temporarily. Oh, এখানে তোমার তো recording শুরু হয়েছে অনেক recording. So recording actually what I do in the keratome, I give incision to the capsule, which you can see the capsule is inside there in the center and slightly different from Dr. Banerjee inside the capsule in the rhesus fossils cell. So I inside the capsule there and then I do visco. So the flap is very inverted there and waiting to be rhesus to be done. Then I'm doing the side put incision and I give the side put incision as you can see as tracked by the cranium. And once that is done, I'll do the rhesus. This is 5.1 millimeter size rhesus. So that this will go off slightly. Still, I have enough rhesus margin to cover the lens. And I use the fossils as well. As you can see, I don't hold the eye. I don't hold the eye even during the incision or side incision. And so I just instruct the patient to cooperate. And I do the rhesus without holding the eyeball as well to be as much as traumatic as possible. And now you can see I have completed the rhesus 5.1 millimeter rhesus. Sorry, slightly resected. Now I'll be doing the hydro dissection. Again, during hydro dissection, I have to let little bit of visco out and then do the hydro dissection. In this patient, the cataract is not very hard. So in my mind, I'm thinking of trying reshopping the nucleus and separating them. So after releasing little bit of visco, I'm doing the hydro dissection and you can see the wave of the fluid going below the posterior capsule and you tap the nucleus gently at each stage so that you're letting the fluid from behind the nucleus to escape as well. And once the hydrodissection is done, I use ocular or phenoclip glass, no financial interest at this stage. And once that is done, here I am trying to do pre-shopping. So let's say to fast. একটু এই সময় চপারটা নাও কি করে so I'm waiting for the pre-chopper to be not rotating the nucleus just gently rotate the nucleus. I'm waiting for the instruments actually because the nurse capacity will be very good but she doesn't know my stage so I'm a little bit of time we have to wait for the instrument. So now I am on the anterior chamber and I'll attend hydro, attend pre-chop. In pre-chop, you have a sustainer which you go with the left hand, go under the capsule at opposite to the wound, and you have a pre-chopper where which you go from the main wound and they try to cut through the nucleus. So here that is the sustainer which I am going under the capsule and that is the pre-chopper which I have to deepen and then you separate. So the cut was not very good. So actually I failed here to do the proper pre-chopping. There was cut was there but it was superficial. And here again also it was a bit superficial pre-chop. So I thought okay I'll go with normal direct chop. It fast forward because they will be giving the instrument. So again, every step I form the anterior chamber with viscoelastic and My setting, as you can see, is what was RP 26. Okay, and aspiration is no. This is actually my RP is 22, and this is for the chopping, and aspiration is 26, and vacuum is about 450. So I do direct chop of small pieces, 6, 7 pieces as many as possible, just gentle on separate. And because of the RP is low, sometimes you can lose the bolt. But here you can see after the first thing, it's going on beautifully. So you just gently do vertical chop and separate the nucleus pieces by pieces, as many pieces as you can. I'm using a sharp Mohandrajan chopper of 1.75 millimeter, and once the separation is done, I will move on to segment removal. So here you can see I have about 6 pieces, and again I am moving to segment removal where the arm is 26, and vacuum is again more or less the same. So while segment removal, you bring the nucleus to the center and then go full throttle so that you don't in soft cataract you don't go through into the PC. So you bring the nucleus to the center and then go full throttle to take the nucleus out. It's a soft cataract, quite soft cataract and quite easy to remove the thing. Once you have done, ideally as you can see, I have left my faculty there so that there is no sudden deformation of the chamber, no incidence of PVD delays in those situation, and filling the antigen chamber viscoelastic. And once you have done that, then only I take my faculty power. Now, while doing my irrigation aspiration, fast forward principle, I keep my aspiration. I start my aspiration with the left hand. As Dr. Shukita has also shown, aspiration with left hand. The advantage is then you can swap over and you can do high utilization when your irrigation is in the right hand. So here my irrigation is in the right hand and I am doing my aspiration with the left hand. And I do as much as possible, then I swap over. And as you can see, I have actually completed my aspiration with the left hand only, so I have to swap over anyway to insert the lens. So I'm injecting a 25.5 diameter canoptic story. I normally use a screw injector, but here Dr. Lutro and Shruti told me that you will be absolutely okay with push injector, and with their experience and their guidance, I have gone with the push injector. Uh, and you can see the idle is very simple. I just nudge it slightly before it opens up. You can do anti-clockwise nudging as well as I've done so that your position becomes little easier. You slightly undercurrent in the beginning, and once the haptic opens up, we start there. So you have to separate it from the optic, and once it's open up, you can see it's quite positioned well because hybrid plantation. The advantages of hybrid plantations are that you don't have to remove visco from behind the nucleus. There is no possibility of, or less possibility of IOP rise because no visco is there, less possibility of task. So these are the advantages. And I have positioned the items, so I think we just shift to the next case now. I'll be doing for the lack of time, so I'm doing hydration, and I'll be giving intracameral antibiotic and give a small air bubble. So you can see the lens is very well positioned.
Wonderful, fantastic surgery, Subhadra. One thing I also add to this, during the visco removal. So, what you have in hydroimplantation, another advantage is that ELB. if there is any visco remains in the bag, which is difficult to remove, that might cause some forward displacement of the lens for sure. And since this is a premium lens, is so any little bit of angular displacement, so 1 millimeter displacement can reduce 1.2 millimeter to 5 diopter, the thing. So this is very important. So wonderful job.
Thank you. Thank you.
And also, I make a little comment on your the chopping technique. This is very difficult. I'm saying it is very soft cataract. Multiple vertical chop is really, really very difficult. That's a fantastic job.
Thank you so much.
Thank you, sir, for the wonderful study that you have shown us. We move on to the next speaker, Dr. Rudra Krishna Ghosh. Again, a prolific eye surgeon, teacher to many. So he will be performing a case with Clarion chronic eye, EP model rotation. Here has been done. The eye will be placed at 171 degree, the linear almost the temporal 180 degree axis. He is operating at the patient has been prepared for the right eye with the pre-operation test connected of 24 and application of 5 lines.
Good afternoon, audience. Can you hear me?
Yes.
Thank you, Shivaji, for your kind words. At the outset, I'd like to thank Dr. Anup for having me here and West WB for organizing a fantastic conference. So my case is a NS grade 3 cataract, which we have planned to be eyewear. In this case, it's a Clarion Panoptic Story T3. And my, yes, Clarion, yes. And my incision site is supratemporal, that is 120 degree in this case. Yeah. And my size of braces is 5.25. That I usually do in every case, and also I'm doing with that 5.25 incision here. And for the sake of clarity, I have given some amount of glue so that it's better visible in the camera. And
Stripe and blue.
not only for viewing purpose. Yeah. And in this case, I'm using HPMC for my Rexis purpose. And this is my standard procedure of doing Rexis. I usually do with a 26-inch needle. And actually, different techniques of giving motivation, but yes. But anyway, yes. It's been a beautiful Rexis with the needle. And again, before we blink, he has completed that is for hydrogen. Yeah, I do a multiple segment hydrodissection. And after hydrodissection, quite a and this tape I have learned from Dr. Neko Rosatelli from physics. I do a multiple rotation in both the clockwise and anti-clockwise direction. Yes.
Yeah, this is very, very important step because this makes your chopping.
Yes. If you go beyond the cortex, beyond the epicortex and do the rotation, then most of the epicortex also get removed. Exactly. That becomes very easy. Yeah. Very little IA. As you can see, the patient is uncooperative. No, this is not an uncooperative patient. He was very uncooperative, and I have to ask him 100 times to look at the light. You see, I am using a Mohan Rajan sharp chopper, and I will attempt a direct chop. What I do, it's not a classical direct chop. I do a crater and chop technique. I do a crater in the middle part of the central part, and then I do a vertical chop. Yes, that's my normal technique for almost all the cataracts. Comparing the grade 1, grade 2 cataracts, those are I employ some different technique.
Patella.
Yes, this is the patella fracture that I have made. I am using this technique for many years, but recently I came to know that.
Patella fracture.
Yeah, in case of grade 3, grade 4, grade 5 cataract, the inner nucleus comes separately as a round thing and chunked as a patella type of thing. And in a recent conference, I got that the name of this thing is a patella fracture.
Basically, if your fat does not extend to the center parts, that So even just not only ribs, even before you can blink too much, interest is also done. Sometimes you did a very good job.
I think that's a very small chunk of details. So again, I have to take my paper and go inside and take that chunk. I've taken the individual with the paper itself. IOP aspiration is 40 and practice is 400. Do you change your parameter at the rate of the surgery? Yes. Great. I usually do a implantation in all my chronic cases, but here, as the patient is very uncooperative, I need a visual implantation. As you can see, I am cleaning all the cortical matches segment by segment, and still a small part of the pieces is there, and then brushing between my two really another and take it out. So obviously there is advantage of doing a hybrid implantation that will reduce the chance of rotation, the chance of rust, the chance of some other viscoelastic related problems. Here I mentioned polishing. I'm in favor of polishing the equator and the central part of the posterior capsule also. Now the implantation axis of my lens is 171 degrees, so I'm very perfect in placing my toric lens. So I will take the help of a variant system to implant my IOL. So in Alcon design lenses, there are 3 dots which are near the haptics and optic haptic junction that have aligned to the variant guided positions. Here it's almost placed 171 degree axis, and as I have given viscoelastic.
Do you decenter a little bit from your axis before you?
Yes, I do under correction after giving the vibration. I usually give to my final correction. Then you can see. Now I have a final state left. I take my dialer and a final 1 degree, 2 degree rotation. Yes. This side dialer. Yes. But you can see the patient is doing a disco dance with his eyes, so I have to do this compromise.
Rudra is also doing a dance. Thank you, Rudra. That was an excellent surgery, and can we have a round of applause for Rudra? Switch over to the next surgery.
Thank you, Rudra sir. So it was a wonderful surgery. So we'll have our next speaker, Dr. Subodh Paul, with us. I'll request Dr. Subodh Paul and Rudra sir to please come here.
Shivashish. Okay, because joint issue has surgery to do, okay, surgery will moderate that.
formulations that are available in the market. Some person may not be happy. So I will be presenting such one case. This is a 55-year-old female, conducted the down 1 year back, but taken for hunger nutrition option for the 6 months, and she had a full thickness macular hole. So I'll be doing the steps on macular hole surgery. I'm using constellation vitrectomy system, 25 days. 3 ports are made standard made, 3.5 millimeters from the limbus, then steps of the macular hole surgery mainly involve vitrectomy, which include posterior vitrectomy. Then IL peeling, followed by gas component and protection. So to start with, I am doing just anterior vitrectomy. Anterior highlight is anterior vitrectomy just bend the leg under direct observation on the microscope. Then once anterior highlight is broken and anterior vitrectomy is done.
How big is the macula?
Macula is approximately 550 micron.
What is your plan?
This is incomplete DVD. So I do only IL peeling and see.
So no inverse peeling.
No. This is full vitrectomy. After full vitrectomy, I will do PVD induction. So usually most of the time nowadays we do direct PVD induction without transfer light. But as it helps clear recording, so I am using IPTA here because it will give a better visualization. You can little bit forward for 30 seconds. So now I am using 650 suction. It's a 25 days hyperpeak. The cartridge is 20,000. The maximum cartridge available nowadays. I'm going to just margin of that is the pathogenesis of macular hole is important because PVD, anomalous PVD is the main cause of macular hole. So most of the time, vitreous is tightly added to the disc. So you can see it is also added to the cranial surface also. This clearly visible that PVD infection has been done. So I will now do complete vitrectomy. Unlike in case of retinal detachment, vitreous base shading is not that important, but particularly when I am using the active port, that is the supratemporal because it's better to do complete vitrectomy at the base because I have to use the second instrument so that there should not be any traction. Now vitrectomy is almost done, and you can see the hole.
Will you depress and see the periphery?
I usually after gap fluid exchange, it is usually visible after tilting. No rate of depression kind of down I do always. So here I am using brilliant blue dye. I think it is quality is good. Thank you, Karki, for helping this 4K DSLR camera. After staining, I am using macular contact lens. It gives better synopsis. Here I am doing just pinch and peel technique. Usually supernasal to the macropia to start pinching. Finally, to identify little bit, I do first across the hole. Then I complete the macular identity. In this case, little bit of potential hemorrhage is very common because molar cell is a distant membrane of the molar cell. So island filling is down 360 degrees around the hole. Initially, it is little bit less, so I am doing secondary repeat filling to enlarge the filling. Now I am happy with the filling. So next step will be the air fluid exchange. fluid exchange, I usually do active fluid exchange, that is the butter only. I do suction, just seeing the filter, final filter. Now we have fluid exchange. Here I usually I do vitrectomy surgery with 35 mm of mercury. During active suction of the fluid, I use 6 mm of mercury. It helps better and it's good suction. The final small part of fluid I remove with passive section. From the disc. As you can see, why I am not doing islet filling. Here I want to see, yes. I will use this small silicone tip to keep just gently over the macular hole, and macular hole will close from the table. I will be able to see the macular hole is now closed. If you see carefully, the macular hole is almost closed now. So rapidly, quickly, I remove the hooks, all the hooks. Now inside there is only indication for this inverse flap technique. How big the hole you do the inverse flap? If I usually do not do, sometimes I am telling you, one time 600 micron, then I will do. And if there is a less fluid on the OCT, cup of fluid is no cup of fluid, then I do. From the OCT, I decide whether it actually will require a filling, islet filling or not. Because if it is elevated, then with I use 27 because cannula, suck the fluid directly from the macula and try to use it up again. And in inverse islet filling, I still feel in some cases, though good poses, but this one outcome is not there. Somehow it's my preference. So in cases of large hole, when there is a flat hole, then only I use inverse islet. I put the silicon tip in the center of the hole. That is a conventional way. But very softly with high magnification, I use it. Now, if it is a very large hole, as you were saying, mostly you don't do a reverse split. So, will you drain from the end of macular hole? It is very difficult because then sometimes islet comes with when I try to suck the fluid. No, you are not keeping the island because you are not doing an inverse flap. No, in just some large I do inverse flap. Okay. So that was an excellent surgery, and I think you took less time than a couple. Yes, it took 12 minutes. Thanks, sir. Fantastic. Thank you. Thank you, sir. We will be moving on to the next speaker, next surgeon, Dr. John Gupta. So, share with us the surgery to be performed with clarion chloric acid D3 or 22 diameter left. So this is the pre-op workup.
Recording.
This is the pre-op workup of the patient.
Forward. We will just do a little bit of fast forward to the figure multiplication because I think that there is not much difference in the initial steps that we all perform. So we will move on to the figure multiplication position and the back. Right. This is the position. So
Ashita, your parameters,
Yeah.
tell us your parameters. I know you operated very low.
So the parameter here is kept at 2060 and 700, and the whole concept behind it is to keep the machine at the maximum efficiency and achieve control over the full level and deliver as and when required. So keeping a 700 plus vacuum or keeping an aspiration of 60 doesn't mean that I am working at that parameter continuously. So we all stay on our sweet spot, but in situations of need, we can use the full efficiency of the machine to reach a vacuum more than 700, and that actually gives us the better control over the pieces, reduces the surgical time, and also reduces the total energy delivered inside the eye. So with such a hard memory cataract, you will see that we are able to keep the CD rested. So Basically, the techniques are all the same. So we all do a central direct job. We will separate the pieces, and then once we start the emulsification, we take the help of the energy as well as the vacuum in the aspiration process. So that is how you are reducing the total. So it is not about like in paper we all understand that we deliver energy, but gradually the concept is moving from an energy driven system to a fluidic driven system. And when we call a fluidic driven system, what do we have in mind? We have only vacuum. Right. And outside. Right. Yes. So use the vacuum to its maximum efficiency. And this is why the Centurion stands out so clearly because this is an absolutely dissociated setting. So 20 means the inflow is very low, 60 means the inflow is very high. And the vacuum of 700 plus means we are making the machine work at its full. But do we do that continuously? No. We stay at 550, 600, 650. But when situation arises, we can reach 700 plus. And that is the logic of this particular setting. So once it's done, I think the lens implantation is again the same. I think this was the case of panoptic storage, or it was the case of living storage which was implanted. I do not recollect the model of the lens. So is there anything you can fast forward with that motion with the living lens? Because take it forward.
Sure. Then centralization versus that.
So I always do implant active because original cortex to killer cortex one. Very good. I pretty good.
You usually use a single board.
I use a single board unless it's a small business or bimanual is in select situation. So mostly I use a projection and I would use a wound assisted delivery system. So that gives me control. It's a so AI do that. And obviously one step that because I put it under visco in all the cases, the very important thing is washing the visco from it. Now this is interesting. Can you go a bit back to the fluidic portion of the that panel and pause it over there. So look at the parameters. So the CT is very low, the fluid use is very low, the fluctuations are very low, and the portion that you stay in that longitudinal and the torsional, that is the perfect balance. So when there is a complete operation, the longitudinal, the ID of it gets activated, the longitudinal works, and this is how you actually control the energy within the eye.
Right. And this should be the ideal situation. The ideal situation.
We should try to achieve this ideal situation.
So from this platform, this is also for the learning of young generations because earlier this clinics was not. So now they do have good machines. So this is an ideal thing that Johnsita has shared with us that we should try to achieve this. Although it is in Hindustan, it looks very easy, but it takes time. But still, to reduce the CD loss of energy, so this fluidics can be a very important role. How he has described beautifully.
With Anup's permission and on request of album, they want to show a recording on Unity chapter system. So we can just switch off to that. The same thing, we will move to the frequency multiplication portion. I will just we'll show the frequency multiplication on the fast forward. What is the frequency multiplication? Yeah, we can say also. Yeah. So this is also a machine where I was initially asked you should not do on 26 and 700. Then I said that then the whole money is a waste by I'm not able to start at 26 and 700. What it has achieved? This machine has achieved a better control of the fluid system. So the IoT sensors are more stabilized. As a result, the fluctuations of the chamber are reduced. Your holding, etc., is absolutely the same as your section because you are able to reach the similar plus vacuum more easily, and uh, also the chopping and everything becomes easier because it is related to the holdability. But the difference is when it is talking about the emulsification process, which is a four-dimensional volumetric displacement of the nuclear material. And see, with such an equivalent rate of scattering as we did prior to this, where we reached around 700, it's a large scatter of equal grade. See the amount of CD that we achieve in this situation post completion of the frequency process is around 2.3 mark. So the unity, what it is doing, it is actually bettering the fluidics as well as it is making us more energy efficient, and it leads to a 50% reduction of the total energy delivered inside the eye. But the most important function that I feel is added to this machine is, apart from the active sentry, is the thermal sentry. Because with thermal sentry, what happens when we are reaching a 90%, 80-90% of the energy that is preset, the the delivery mode changes to the pulse mode, and automatically it reduces the temperature inside the eye from a continuous mode of delivery to a pulse mode. As a result, the damage to the endothelium because of the increased delivery of energy for the harder cataract remain minimal. And what we have seen till now in the post-operative period is the cornea is absolutely untouched in cases like when we have a fused dystrophy with the heart cataract, when we are understanding whether we should do a triple transplant or the PXA with a compromised endothelium. In those situations, this machine, my experience with this machine is very new. I have only done around.
Beautiful demonstration of this surgery. Thank you. And we switch over to our next video by Dr. Surgery by Dr.
What was it?
So, Shubhata, so that's right.
Now you can see the this is a post operation photograph, group photograph. You can see my patient is standing tall. It is malformed hepatitis. This is malformed. This is a case of some accident. And on either side are Mosharaf and Paulo, my assistant, and Moralisha and Ilma. They are doing body separation. So this is the malformed case. This one is finger body close to face, bilateral subluxated legs, which is already cataract start. So this plan is to remove the cataract lens and do eyes cross lens. I do first posterior peripheral consultation as a digital surgeon rather than using bipolar cataract. I am using unipolar purpose here. So first I do the tunnel, but incomplete tunnel without entering practice so that interpretation is maintained. Just tunnel without entering. Because I am planning to do iris flow as well as removing the legs to this part. As you know, these smartphone cases are, though they are subluxated, journals are most of the time intact, unlike homocystinuria. In this case also, 360 journals are intact, but they are very lax. And because of long-standing cataract, size of the legs is a little bit less. So it is basically lax cataract and it's almost in the not millimeters but 5 micrometers. I always prefer vitrectomy here because in this case, after only after vitrectomy, post-operative compressor are must. Now after doing 3/4 and doing the side ports, just 2.75 millimeter ACL. Not complicated because it will destabilize particular. In this case, it is very difficult to do from only anterior route without posterior vitrectomy because legs is going downwards. So we have to insert the make this little bit posteriorly, may not be possible. So unlike normal cataract surgery, each and every vitreous retinoid surgery is a difficult. There is no prefixed plan or fixed procedure that can be done. Here I am doing just a little bit of anterior. Now I am trying to push the legs in the anterior chamber, but I am seeing 360 journals are intact and they are so intact. If I leave it, legs will go immediately behind. Here I am trying to cut the journals with detectomic cutter. I am trying to push hard, but journals are not broken yet. And every time I am releasing the pressure, it is going in that. Now you can see the journals. All the journals are intact. And this is the first time I am doing just to tear the journals with the tip of the side foot. I've never done it because most of the time I have seen little bit journals are usually damaged, and so that I can make this inside. Again, it is I'm not happy. So I'm giving pressure and counter pressure, and really I'm injecting some. I want to inject some disco. I'm trying again to break the journals like I can open up the rexis with both these. Now I'm little bit successful. If I release the pressure from behind, the legs will go posteriorly. Still journals are in so much pressure also. Injecting disco in the anterior chamber, giving pressure, pushing the legs from the posterior part. I asked my assistant to stop the infusion camera here because I am increasing the excision, otherwise I will collapse with high chance. Little bit more disco to push the high stab from behind. First secure, very difficult at that time because the entire journals are pulling the legs backwards. Now I need infusion is off. Little bit of disco to form the attention part. It's can decrease. The another option was to drop the whole cataract and do the defectomy and phacopragmatism. In that case, I have to increase the remove the one foot and have to increase it to 20 days because sutureless height is phacopragmatism is not available. Now nucleus is totally out. Using a little bit of pyrotherapy to constrict the pupil. Vitreous is there in the anterior wound, so I am removing the vitreous from the anterior wound. Vitreous is still inside the anterior chamber. As you saw by picking of the iris clearly with a spatula, just remove the vitreous from the anterior chamber. Pupil is now circular, little bit of legs matter is there. Yes. Now pupil is circle, that means vitreous is not in the anterior chamber. So after that, I will complete vitrectomy as much as possible and see the retina whether there is any retinal lesion or not. So here is the This part is by Apashami. It's quite good. And since the retina, there is no predisposing lesson like diabetes or eating or etc. And in this case, there was PPD was complete, and because was equal fat. So vitrectomy is done. Now next part will be the insertion of iris wire. Yes.
Just I have one question. Shuru. Not using a tripod at this stage, was it because the PPT was small?
Yes, yes. I can see with the visualization system. We can see whether it is PPT is there or not. I forgot to stop the infusion camera, so I is a little bit collapsing. Now infusion is off. After pump disconnection, this lens is actually my preference is iris lens rather than scleral fixation IOL because there is no sclera root here and each and every part of the lens is inside the eye. Even if we dislocate, we can re-implant later on, and it is very quick procedure also. And for the last 10 years, we are doing iris lenses. The competition are much less than the scleral fixation eye. This compression and pressure comes in practice. This side is very good, otherwise we will make iris more sometimes. This is a dot film iris for 100% and it's dead since skin. Iris is perfectly circular. Two dimples shows the where lens flaws are there. Surgery is done. I will put one suture in the center and remove the bismuth. Other has same condition, maybe we will plan later on.
So I have a question. If there is a previous SSS in the temporal side, and we are entering from the temporal side. SSS would not previously.
It can be done. Sometimes I have done even I will cause the face body.
What is the 6 and 12? No problem.
In many technical they are in the red. I have done. The clear body is extended and I will look at the question.
You have an age for selection of the iris flow lenses.
Actually, there are studies from people and other area also. Iris flow can be put in younger age also, even less than 10 years. I have used some cases of pediatrics, some cases of cataract, and for last 10 years, it's doing well. One or two cases of iris flow dislocation is there, but it can be real. Here the iris flow blade is too much because we get a lot of complications here. But in fact, many of the cases of retinal surgeries are basically vitrectomy plus phacocytomy and iris.
Sir, I have a question that you fix the ice flow lens, how to maintain the circularity of the movement and also maintenance of anterior chamber, meaning implantation of the eye in a vitrectomized style.
In vitrectomy, good. Speculum, first of all, speculum, it should not be too much tight open because it will give posterior pressure. You release it first, give as much viscosity as possible. Posterior iris block or should not raise the posterior lip of the sclera. That is most important. Little bit visco will come out, no problem. You can do inflammation of the one block, then come out, give viscoelastic again, and to with the second floor later. That will help. In vitrectomized eye, you can keep the inclusion open with only 10 mm of mercury pressure. Otherwise, iris will keep on collapsing.
Yes, okay, thank you, sir.
Do you have any other question? I think it's a fantastic surgery, Shubham. and beautifully done. Beautifully done. So we will have our next demonstration of surgery by Dr. Shukriya. While he's getting wired up. So what was the case? So in case of with little bit of margin, the idle power was minus plus 18 with minus 2 cylinder. So the patient was questioned for trifocal colic, particularly it skipped enough colic. Please proceed with the solution. First, I side sports at the desired positions. The drill was not moving forward, so correcting the drill position. And now starting with the surgery. First, I start with topical cases. I start with the side foot, making the side foot and putting some phenocantras inside the anterior chamber so that the patient doesn't feel anything. And the side force, 0.9 mm side force, putting in some phenocantras, maintain the direction and to keep the patient some comfort.